Welcome to everything you need to know about assessing hormones, how to do the testing. We've decided to do this as a webinar because we don't really have a lot of time to do it during the module itself. I am hoping that you are actually listening to this prior to getting to Denver, because that'll make your life easier. We will be sort of reminding everybody on the first day. So some of you may be listening to this the first evening. You're going to find that you really do need to have this information under your belt because we're not going to have time to talk about it much while we're there. Okay, here is the probably single most important thing you need to know. Hormone therapy is definitely an art, not a science. I've always said that if you find, 5 or 6 practitioners who do hormone therapy, you will find 5 or 6 different ways to make a prescription and way more ways than that to actually do testing to monitor it. The important thing is that you keep in mind what we know scientifically is a better or not so good way of taking care of the patients in terms of the testing. And then find what works for you and become the expert in that. Because if you're consistent over time, you can kind of work around the pros and cons of every given testing modality. And you can pretty much figure out what you need to do regardless of what type you end up doing. Alrighty, so what do we need to worry about? We need to, in order to evaluate hormones, you need to know what to test, when to test it, and who you're going to test. So we're going to talk about all of that. Now, there's a zillion different potential problems in measuring hormones. I mean, keep in mind, hormone levels fluctuate a lot. Some vary during the day, some vary during a cycle. Some don't vary at all, so you need to keep in mind which ones you need to worry about in terms of fluctuation. The studies that have been done typically don't measure hormone levels at all. So finding the, quote, normal is sometimes problematic. And in the studies where they have come up with, quote, normal hormone levels, a lot of them are much older studies, and the methodology was more unreliable than what we use now. And it may not even be comparable to what the labs currently use. So that keep that in mind in terms of what people are calling normal hormone levels. A lot of these studies also would average out non-comparable groups. I mean, basically they would be comparing, they'd have a group of apples, oranges, and grapes and put them all together and say, oh yeah, so this average is going to work. So it's kind of like doing a meta-analysis. If you're taking a bunch of different data, you can't necessarily say that this average makes sense. You probably are already aware of the fact that different labs end up developing different reference ranges. And so if you use multiple different labs, you can't necessarily compare the test results that you're getting because the reference ranges aren't the same. And sometimes even within a given lab, depending on which test kit they happen to use, like a test from, say, Quest, one day they'll use one test kit, so a reference range will be XYZ, and another day, went to the same lab, but they used a different test kit and they have an entirely different reference range. And so you have to point that out to the patients, because if you've got a smart patient who's trying to keep track of what's going on with themselves, they may get the wrong impression. And you may also actually not remember it also. So keep track of that if you've got different reference ranges showing up on your test results. Now, there's big variations both between individuals and even within the same individual. So between different individuals, the serum concentrations of both natural and synthetic steroids might not really make any sense. There's huge variation irrespective of the route of administration of the hormones. So what you expect for one person may not actually be true for the next person. And of course, within any individual person, you're going to get levels of fluctuation throughout the day based on lots of different things. Everything from perceived or actual stress, that's going to change what your hormone levels are going to be showing. Foods that were eaten that day can make a difference. Hydration status can make a difference. So some of the variation that you see person to, within an individual person, but different blood draws, can be based on just what was going on that day. So try to impress upon your patients as you're getting testing done to try to keep the blood draw days kind of the same. Always same time of day, always, fasting, that sort of thing. Now, measuring in different body fluids like serum or urine or saliva doesn't necessarily tell us about concentration in other tissues. And that you need to keep in mind because you may get a false sense of security. And it won't really necessarily have anything to do with the tissue you're trying to treat. Now, this picture you might recognize from AFMCP, if you remember that. This is basically just to remind you, as an example, all the different kinds of estrogens that we might need to keep track of. So when we say there's estrogen, there's actually an estrogen pool. There are, there's free estrogens, there are bound estrogens, there's the production of estrogen in a woman or a man, him or herself. There's exogenous estrogens that you may be giving them. There's stored estrogens, there's the metabolites, there's all these different estrogens you need to keep track of. So this is just one example of having many, we talk about drawing an estrogen level. Well, what is it you're looking at? I mean, is there any possible way that one test could give you all of this different information? And this is only estrogen. The same thing is true, although not quite as complicated. The same thing is true of other hormones as well. Now, for progesterone, this slide you may also remember from AFMCP. This is one example. The same, we have other slides that look like this for the estrogens and testosterone. This is just to remind you of all the different variability there is, and to remind you that what you're seeing as a, quote, average is really kind of crazy if you look at it, because the shades of green in the middle are showing the variation between different people at their biological stage in their life, so premenopausal, postmenopausal, whatever. The lighter shade of green on the outside of that is the intercycle variability from within a given woman, and then the yellowy green is the interwoman variability, meaning one woman to the next. And then that blue line in the middle is the average. So if the reference range is the blue line in the middle, look at what information you might actually be missing. So this is just to remind you to take everything with a grain of salt. And this is true for progesterone, testosterone, estrogens, all of it. All right, so let's get down to the nitty-gritty of doing the testing. We've sort of revamped this, and we've put a lot of these slides into simple graphs like this for you to try to make it as clear as possible. We're going to go through all the different hormone types, all the different ways of testing them, and the pros and the cons. So keep this handy until you kind of have a feel for it. So for the estrogens, estrone, estradiol, and estriol, as well as the estrogen metabolites, in the serum, the good news is it's measuring endogenous hormone production. There's decades of well-validated research on serum hormone levels. So if you get a serum hormone level, we know what those results actually mean. Now, the bad news is these results are giving you the free and bound hormone. It's giving you the total estrogens. You can't order a total estradiol and a free estradiol. They don't offer that. There's some limited data in terms of serum levels of these metabolites in terms of prediction for health risk. And it can be difficult for some labs to get accurate quantification in postmenopausal women because the estrogen levels are so very low. So keep that in mind. And again, that's a matter of knowing your lab and knowing how accurate they actually are. Now, when it comes to saliva, the good news is it's non-invasive. You can do this at home. That makes it really convenient if you're trying to do a serial measurement of estradiols across a whole cycle in a premenopausal woman, because no one in their right mind is going to go to the lab and get blood drawn every single day. And we know that the salivary estradiol actually correlates well to the free estradiol in serum. And so what you're seeing in the saliva is actually what we would like to be seeing in the serum, and we're not. Now, the bad news is about saliva, there are fewer validation studies compared to serum. Now, there's still quite a few, so it's a valid way to do testing. It's just that it's not as well validated as serum because it hasn't been done as long. Again, it can be very challenging for some labs because the level of estrogens in the saliva are a lot lower than that in the serum, so you have to make sure your lab is doing a good enough job assessing these very low levels. And you're going to hear me say this for every single type of salivary testing. Of course, it can be contaminated by blood from the oral mucosa. So if your patient has periodontitis, or something along those lines, you don't want them doing salivary levels. Tell them to do it before they brush their teeth, not after, in case they bleed when they brush their teeth. But that's true of any salivary test. And you can't get estrogen metabolites done through the saliva. And the bigger problem in a postmenopausal woman is that a lot of folks get dry mouth after they hit menopause. And so it can be really difficult to just do the test because you can't produce enough saliva to get an adequate specimen. Now, for 24-hour urine testing for estrogens and estrogen metabolites, this can be helpful if you're trying to get total daily production of the hormones. You can get measurements of estrogen metabolites, and these metabolites are stable for a long time, so it's not a big deal. You got plenty of time for processing, and you can get both free and conjugated estrogen measurements, so that's helpful. The bad news, which is true for any 24-hour urine test, is it's relying on accurate volume measurements and complete collections by the patients. And you know, a lot of patients will inadvertently screw that up, like they'll have a busy day and they'll go pee and then go, oh yeah, right, I was supposed to say that. So that can be a problem. So please make sure the patient understands that. You cannot use this for people who have renal dysfunction because it's based on creatinine correction. So if their creatinine is abnormal, then they won't be able to give you an adequate, appropriate level. And they'll sometimes give you, some of these tests, different labs that do 24-hour urines, they'll give you a bunch of metabolites that aren't really very clinically useful. So it's like interesting information, but you don't really need it. Now, for dried spot urine testing, you can get estrogen metabolites, which is good. And you have the same thing, the metabolites are stable for a long period of time, so that's no problem. And you can measure both the free and conjugated estrogens on these spot urine tests. The biggest problem here, and we have it in bold, is that it has the least number of clinically valid studies, clinical validation studies. So it's a newer way of testing. It is popular and it's easy for patients, but there is a little bit of concern because of the few clinical validation studies that they've actually done. Now, some additional challenges that I want to mention. Think about what a lab has to be able to do. The measurements they need to be able to get have to vary enormously because there are very, very low levels of estrogens in elderly women, not on hormone replacement therapy, and in men. And then all the way up to being able to measure these super high doses in women who are getting ready for IVF. And, you know, the levels can vary by a factor of 10,000. So is it really even reasonable to assume that any one type of test is going to be accurate for all of those circumstances. Now, it can also be difficult to try to assess estrogen levels in women being treated with aromatase inhibitors because they're going to have, hopefully, very low concentrations of estrogen, so that may not be accurately detected by standardized testing. And then specificity is a problem because we talk about how estradiol, E2, we focus mostly on how it gets broken down into estrone and then how the estrones get broken down. But the reality is estradiol is converted to more than 100 different metabolites, and that may interfere with accurate quantification. So labs have to keep that in mind and making sure that they're getting adequate specificity for you. Another interesting tidbit is that exogenous sources of estriol can lead to falsely elevated levels of estradiol. So keep that in mind in case you come across a really funny test result that makes no sense. All right, let's switch to progesterone. Progesterone has its own problems, different from estradiol. Progesterone and the progesterone metabolites. Well, in serum, there's lots of literature to support the use of using a progesterone level drawn, hopefully on day 21 of a 28-day cycle, as a method of confirming ovulation. So if you want to use serum progesterone levels for that, it is totally acceptable. The reproducibility of serum levels are really limited if the serum levels are low. So what that means is if you were to take a person in the first half of her cycle and draw a progesterone level 3 days in a row at the very beginning of the cycle when the progesterone should be low, you may not actually get similar numbers just because the levels are low. So the reproducibility kind of makes me a little crazy, but that's something you need to keep in mind with the serum. Now, in saliva, again, it's non-invasive. It's convenient to do if you want to follow an entire cycle in a premenopausal woman for the same reason that no one's going to come into the lab and get their blood drawn every single day for 30 days. Also, there is research to show that a salivary level of 17-alpha hydroxyprogesterone is just as acceptable as a serum level for the diagnosis of congenital adrenal hyperplasia. So if you got somebody who doesn't want to get their blood drawn and doesn't mind spitting into a tube, you can use this instead. Now, the downside for salivary levels of progesterone and its metabolites. You've got a rapid fluctuation of progesterone levels in the saliva. So if you really probably shouldn't use just one test result to make a decision. You may need serial sampling and kind of get a feel for what the average is. There's also a problem with cross-reactivity with immunoassays that might affect the results. And again, same problem in terms of having much lower progesterone levels in the saliva than in the serum. So for some labs, that can be challenging to get you an adequate analysis. And same problem in terms of contamination by blood. So, but that's true of all salivary tests. Now, the 24-hour urine and the spot dried urine testing for progesterone they have the same problem. Because, well, the good news is the progesterone metabolites will correlate with symptoms. So they've done studies, for instance, that allopregnanolone in urine, the level of that does correlate with the sleep quality in perimenopausal women. And the implication there is that, well, if it's correlating, then it's probably an accurate level. But the problem is progesterone is really hard to quantify in urine. And so they use metabolites for assessment and kind of figure what the progesterone level is based on the metabolites. Okay, that's great, except there's really not any literature describing the clinical utility of progesterone metabolites. So progesterone in the urine is relatively problematic in terms of accuracy and what you're really getting. Part of the issue, this is more details, part of the problem with a serum progesterone is that very, very, very little of it is actually available and non-protein bound. Most of it is bound to albumin and other proteins. It's the free progesterone that is available to the target tissues and also to saliva. So the progesterone that you're measuring in the serum is really measuring mostly the bound up progesterone, not what is actually clinically important. So you have to take that serum level with a grain of salt. The next two comments, there's some hidden slides at the end that actually show you these studies. I'm not going to go into detail about the studies, but what we're trying to get at is transdermal progesterone is extremely difficult to measure what's going on because you get metabolism by 5-alpha reductase in the skin. It's rapidly absorbed by red blood cell membranes and delivered to the tissue. And really what it comes down to is, and I mentioned this again at the very bottom of the slide, after you use exogenous progesterone cream or gel, you get these crazy high levels of progesterone in the saliva and then the capillary beds, not really in the serum. And so there's not a great way to measure what's actually going on. So transdermal progesterone, trying to follow that with any kind of testing is really difficult. Okay, time to switch to testosterone. Now, testosterone and its metabolites in serum, you can get both a total and a free hormone level. So that's helpful. You can also get a DHT level, which is helpful. There are established serum ranges for the diagnosis of androgen insufficiency. There are decades of research of serum hormone levels. So serum levels for testosterone are fine in general. Now, it can be a little bit difficult for in assaying whole serum if the levels are really low, like in women and kids and hypogonadal men. So you need to know your lab and know what methodology they're using if you're assessing testosterone in women, hypogonadal men, or kids, because you have to make sure that they're doing the appropriate type of serum test to get these really low levels accurately. For saliva, obviously very convenient to obtain the sample. There are established ranges for diagnosis of androgen insufficiency, and it's pretty easy to use this testing for differentiating between eugonadal and hypogonadal men, and you can get a free hormone level. Lots of published research on using salivary levels for assessing testosterone. Now, the problem is, just like with progesterone, you get this really rapid fluctuation in the saliva. So you might need to get more than one saliva test result to really get reliable information. So you don't necessarily want to make a decision based on just one result. And again, you need to know your lab because the levels are a lot lower than in the serum, so it might be a little bit challenging to get an accurate level, and be careful about blood contamination. Now, in urine testing, the 24-hour urine and the spot urine kind of have slightly different issues. The 24-hour urine testing for testosterone can be used to get a total daily production of testosterone. You're going to get both a free hormone level and the metabolites, which is kind of nice. And you can use that information to indirectly assess 5-alpha reductase activity and aromatase activity based on how much of each of the different metabolites you're getting. So that's really helpful. There isn't necessarily a lot of data to support the clinical utility of all the metabolites that are measured. And this is just another little fun fact. There is a polymorphism of UGT, UGT2B17, If your patient happens to have that, their urinary testosterone level is going to come back either 0 or practically 0. So keep that in mind in case you ever get back a test result that makes no sense because it's so low, because it may be that your patient has this SNP. And spot urine will give you some of the same pros. I mean, you're going to get free hormone levels and metabolites, and you can use that information to assess the 5-alpha reductase and aromatase activities. The problem is they're, like with the other hormones we've talked about, this testing in general has way fewer clinically validation studies to it, so because it's a newer form of testing. So keep that in mind. Time to switch to cortisol. Now, cortisol and its metabolites in the serum, there are validated reference ranges for cortisol. Lots and lots of peer review literature detailing the use of this test, so you can feel comfortable getting these results. Now, what it's going to tell you is just a total cortisol, not your free cortisol. So keep that in mind. You're not going to get the diurnal pattern at all unless you're going to be trying to, well, you actually can't even get your 4-point test like you would with saliva, because they don't have normal ranges for 4 different times of the day. And my patients actually hassle me about this all the time. If I get a serum cortisol, they go, wait, you don't understand. I am so scared of blood draws that surely that shot my cortisol up, and I don't normally look this bad. So I don't think anyone's ever done that actual test to see how much does the stressful nature of venipuncture actually increase the cortisol, but I imagine it probably does change it at least some. Now, keep in mind that in serum, I don't have this written down, but in serum, they only have normal reference ranges for 2 times of the day, 7 to 9 a.m. and 3 to 5 p.m. So you have to make sure that if you're going to use a serum cortisol, that they go in fasting and before 9 o'clock, or they can go later in the day. And the later in the day one does not have to be fasting. So if you get a cortisol at 10 or 11 in the morning, it's basically worthless. Now, the salivary testing, lots of people are becoming familiar with this. It does reflect both, it reflects the unbound plasma concentration, which is not what we're seeing with the serum, so that's nice. You can obviously get your diurnal pattern because they, many companies have the kits where you've got 4 or 5 samples throughout the day. There's abundant peer-reviewed literature detailing the use of this. And this is for cortisol. This is not for the cortisol metabolites. Now, the problem here is that 11-beta hydroxysteroid dehydrogenase. Now, that is an enzyme that is present in the salivary glands. It's going to lead to pretty significant conversion of cortisol to cortisone. So there is some question as to the result that you're getting in the salivary cortisol. Is that really truly what's going on, or did a lot of it get converted to cortisone and you're not picking that up in the test? So when you're looking at cortisol metabolites in the saliva, which some companies do and some don't, the salivary cortisone correlates with cortisol exposure over a 24-hour period. There's a moderate level of literature using this test, not a lot, but enough that you should feel pretty comfortable. There are issues when your serum cortisol is really low, and it makes it like the patient is really crashing or they're under hydrocortisone therapy. And that makes the salivary cortisone a superior marker of the serum cortisol compared to the salivary cortisol under these circumstances, because of the way that this is being processed. Not that many companies are actually even looking at cortisone directly in the saliva. So at this point, especially because of the moderate level of literature, you're going to primarily be doing cortisol levels in the saliva. So let's move on to the urine testing. Now, in a 24-hour urine test, you're going to be able to assess the cortisol to cortisone ratio, which can be helpful. And a 24-hour free cortisol correlates with the serum free cortisol level, the mean level. So that's nice. The only problem is there's kind of limited clinical validation studies for this. And obviously in the 24-hour urine, you're not getting a diurnal cortisol pattern at all. And in the spot urine, you can get the cortisol to cortisone ratio, which can be helpful. You can have the patient do the spot urine test multiple times a day, so you can get the diurnal change, just like you would with saliva. But unfortunately, the spot urine testing has the least amount of clinical validation studies. So you have to keep that in mind. So with this, primarily people are feeling most comfortable with using either serum levels done at the right time of day, understanding that you're getting, you're not getting the unbound cortisol, or they're doing a 4-point salivary test. I do want to make a comment about the 4-point salivary test before we move on. I used to do them a whole lot. And I kind of realized over time that I could see a pattern between what the patient was telling me in terms of their energy level throughout the day and how they felt, and compared that with what the result came back. And I started playing a little game with myself going, okay, based on what this person told me, I think the test result is going to look like this. And I would draw myself a little note of what I expected the test result to be. I got to the point where I was right so often that I kind of stopped doing the 4-point salivary test, especially if the patient had to pay cash for it. So, and this was in the days before the national labs even had it available. So initially, as you're getting used to doing this testing, you'll probably want to go ahead and do the salivary test, but you may find over time that you don't really need to do it, that you can tell just based on what the person has told you. All right, DHEA levels. And we're going to talk about DHEA and DHEA sulfate separately. DHEA in the serum, there's lots of clinical validation studies, so you can feel comfortable with the fact that you're getting adequate results. Now, DHEA has a diurnal pattern, so you have to make sure they get it done at the right time of day. And essentially, this is fasting in before 9 o'clock in the morning, just like with cortisol. A DHEA done later in the day basically means nothing. A DHEA sulfate, however, in the serum, DHEA sulfate doesn't follow a circadian pattern, so a single test done any time of day is probably okay. And there are numerous clinical validation studies. I didn't put this in officially as a con, but the problem with the DHEA sulfate in my mind is because it doesn't really have much of a circadian pattern, you may miss small variations in a DHEA in a person over time based on how they're feeling and how stressed out they are and all of that. So it's just sort of, I don't have a study or anything to prove that that's a big problem, but I sort of feel clinically like occasionally it's kind of nice to just check the DHEA as long as they're done in the morning, because then you'll get a feel for the changes over time in the same individual that you wouldn't see with a DHEA sulfate. Okay, so salivary testing for DHEA. This gets kind of funny in a way. You are measuring free DHEA, which is great. There's a correlation with serum levels, and it's non-invasive. The problem is the concentration is inversely related to the salivary flow rate. And it's also affected by the salivary pH. So basically, you don't want to have somebody walk past a bakery, start salivating heavily based on what they just smelled, and then go do their DHEA test, because the rate of salivation is going to change the result. There's less peer-reviewed literature compared to the serum, although there is peer-reviewed literature for using salivary levels. DHEA sulfate, same basic problem in the saliva. It's related to the salivary flow rate and the salivary pH. So that becomes a problem. So keep that in mind if you're looking at salivary levels. Whoops. In urine, whether this is a 24-hour urine or a spot urine, there's basically no clinical validation studies about looking at either DHEA or DHEA sulfate in the urine. So keep that in mind if you're doing urine testing and they're giving you a whole panel and it includes DHEA or DHEA sulfate. Don't really know what those results mean. Now, for pituitary hormones, the preferred testing is serum for FSH, LH, and prolactin. Not convenient for serial measurements throughout the day to detect a LH surge, for instance, but the results are very accurate. And in saliva, there's really limited peer-reviewed literature detailing salivary pituitary hormones and whether or not they're adequate. Now in urine, at-home LH detection kits are convenient. They're widely used. They've been around a long time. The LH surge in the urine correlates well with the LH surge in serum. So if you're trying to help people figure out where they are in their cycle and whether or not they've ovulated, then this urine is the way to go. It doesn't really do a good job of quantifying it. It just tells you there's a surge, because these are bigger hormones and so don't really get into urine very easily. So you're going to know whether or not you've gotten the surge. You're just not going to know what the actual level is. And that's okay, because most of the time it doesn't really matter what the level is. So essentially, unless you're just trying to find out if they got an LH surge, you're going to want to use serum for either FSH, LH, or prolactin. And sex hormone binding globulin, most clinical validation studies are in the serum, and you really can't measure it in saliva or urine, so that's easy to remember. So now we're going to go on to talking about, so we've already talked about the issues with different forms of testing, and if you haven't already figured it out, there's not a single form of testing that will give you everything you need to know about every hormone you need to know. And if you don't remember anything else I say for the whole rest of the webinar, that's the most important thing. So now we're going to talk about when to test hormones. Early morning is the time when the hormones are going to be the highest for most gonadal hormones. So probably best to go first thing in the morning, definitely with cortisol, but even with the gonadal hormones as well. Just in order to be consistent, it's probably best to be fasting. Because remember, I mentioned at the very beginning that what you've eaten can change hormone levels. So if you're always fasting, at least you're going to find consistency between specimens in the same person. And you need to know where they were in their cycle for certain of these tests. So for your women patients who are still cycling, they need to record the first day of their next period so that you know what day you actually did their testing. Otherwise, they're going to have to use ovulation kits to know exactly where they were. And of course, the downside here is that if you're trying, for instance, to get a day 21 progesterone, and she typically has a 28-day cycle, so you tell her to go on day 21, but that particular month she has a 35-day cycle, you didn't really get the level that you were looking for. So it can be a little problematic, but definitely remind them to keep track of it so that you'll be able to look back and know where they were when they had their test done. So in pre and perimenopausal women, when do we want to be getting these tests? Well, in menstruating women, shoot for as close to day 3 as you can for an estradiol, an estrone, an FSH, a testosterone, or a sex hormone binding globulin. You want progesterone on day 21. You can also do sex hormone binding globulin on that day. Now, these are ideal. Can you get them on other days of their cycle? Yes, but they won't have quite the same accuracy. And of course, it may not be exactly day 3, because what if day 3 happens to land on a weekend and the lab's not open? So take it with a grain of salt, but these are sort of what you're shooting for. In general, what we're looking for here is to try to test the hormone levels when they're at their highest. And that's why we're shooting for 3 and for 21. So, you know, here's day 3 and 4. And so the FSH is going to be, I mean, obviously you're going to peak here, but you're going to get a nice level here. The estradiol bounces around a lot at this point, so trying to get it in this part of the cycle wouldn't be very helpful. And obviously with progesterone, you're going to get your peak here. So that's why you want to try to shoot for 21 day, because, you know, that's going to be the easiest way to make sure that you're getting it. And also it'll help you be more consistent from cycle to cycle if you're always trying to get it at the same time of the cycle. Now, here's where it gets kind of tricky is, how do we, you know, it's one thing to find out where the person is before you put them on any kind of hormone replacement. Monitoring hormone replacement therapy gets trickier still. So we're back to our little graphs. Let's talk just estrogen replacement therapy. Now, or if you're using oral estrogen, recommended to get a serum baseline before HRT and then monitor during treatment. If you're doing oral estrogen, salivary levels really don't reflect the exogenous estrogen use at all, so they're not very helpful. And oral estrogen, any oral hormones undergo this, you know, the first pass metabolism in the liver, and the levels are not really accurately reflected in the urine. So if you're doing oral estrogen replacement therapy, really the only way to assess it is with serum. It's okay, because we're going to convince you with the module you probably don't want to be using oral estrogen anyway. If you're using sublingual estrogen, the levels are going to rise and fall really rapidly in a matter of hours. And so the serum's not really all that effective in terms of measuring. The saliva isn't really going to make any sense if you're doing sublingual because, well, you just had your estrogen there. So what does it really mean? 24-hour urine and dried urine testing with sublingual hormones aren't really recommended because there's always a question of, with sublingual, how much are you swallowing and how much is actually getting absorbed sublingually. So since you don't really know how much was swallowed and got the first pass metabolism effect, the result in a 24-hour urine or a dried spot urine may not make a lot of sense. Now, so basically, if you notice, that says in sublingual, there's really not any great way to do testing. So that's problematic. Doesn't mean you can't do sublingual estrogen replacement therapy. It just means there's not really great way to test it. Now, if you're using estrogen creams, serum testing can be effective. And we do know that there are clinical parameters that correlate to the serum levels when you're using estrogen creams. And so you can do that. In saliva, estradiol and estriol are actively transported into the saliva. The levels are way higher than you would see in the serum, and they're highly variable. So salivary levels for creams really don't make a lot of sense. And there's not really any good peer-reviewed studies detailing the effect of estrogen cream on urinary levels. So probably not a great idea to use urine levels for someone who's using estrogen creams of any kind. Now, if you're using labial or vaginal estrogen, serum at this point appears to be the best choice for monitoring absorption. The salivary levels don't reflect any dose changes. So basically, it's probably a waste of time to get a salivary level. Trying to do urine testing, if you're using vaginal or labial estrogen, might be problematic because how do you know you didn't contaminate the urine specimen? And if you're using a patch, serum values are going to rise in a dose-dependent manner and then rapidly decline following removal. So it may be helpful. I mean, we do know at least that the serum values change based on like when you put the patch on and when you take the patch off, but it is still a little problematic. There's no peer-reviewed evidence showing that salivary estrogen can be used to monitor the estrogen patch. And when it comes to the urine testing and the estrogen patch, it does appear that the values in the urine will go up in a dose-dependent manner. So that implies that it may be relatively accurate, but again, it's not the best clinically validated test for an estrogen patch. I mean, the take-home message here is basically no testing is perfect. And what a lot of us end up doing is you basically just adjust the dose to the lowest amount, the lowest level you can get and still have your symptoms controlled. That doesn't mean don't test. You do need to test because you want to make sure you're not totally overdosing this person. But just keep in mind that there's a lot of limitations around what testing can be helpful depending on what form of estrogen replacement you're using. Now, progesterone, oral progesterone, if you're using that, the levels rise and fall really quickly. You're probably not going to be able to catch a serum level that makes any sense if you're taking your progesterone in the evening and then measuring in the morning. Because most women, if they're taking oral progesterone, they'll take it in the evening because it helps them sleep. There's also a problem with cross-reactivity of metabolites with the immunoassays. So progesterone replacement therapy, if it's oral, the serum levels you really have to take with a grain of salt. Same thing with the saliva. The 24-hour urine, we talked about how you're really not getting progesterone, you're getting progesterone metabolites. So that might be useful, but there's the problem of how clinically valid the use of progesterone metabolites is. So oral progesterone levels, oral use of progesterone, getting a level and following it is a little bit tricky. Now, with creams and transdermal progesterone, you're really, none of the testing makes any sense because you get minimally increased levels in the serum that don't really rise in any particular way that makes sense. Like all steroid hormones, these are fat soluble. So, what if it goes and sits in adipose rather than getting into the bloodstream? Doesn't really necessarily reflect, a serum level doesn't necessarily reflect the tissue levels in the uterus and the breast, which is where we care about it. So a serum level for progesterone cream is problematic. Salivary levels after progesterone cream go way up, and they don't correspond to symptoms at all. So don't bother getting salivary level after a progesterone cream. There's some evidence in urine testing that you can get small increases in the pregnenolone 3 glucuronide if you're using progesterone cream. And so it may turn out that we can use that as a measure of what your progesterone is actually doing. But this, I think, still needs some more testing. So I guess what you need to keep in mind is there's not really any reliable method to keep track of what's going on when a person uses progesterone cream. So don't fool yourself by getting a level and making a decision based on it. Now, vaginal progesterone suppositories, same problem. You get minimally increased levels in the serum, so probably not giving you an adequate result. There's a lack of any peer-reviewed research at all for salivary levels after vaginal suppositories of progesterone. And then, of course, any vaginal hormones, you got to be careful if you're trying to do urine testing, because how do you know you didn't contaminate the sample? Progesterone melts or troches. Well, you can use serum levels in a troche because you actually get a more accurate level in the serum than if you had taken it orally. You can't really use a salivary level because you just had the troche or the melt in the person's mouth, so can't really use a salivary level. And then there is at least a potential problem with getting a urine level for a troche or a melt, because just like with a sublingual, how much of this are you swallowing? And some of it may be swallowed and subject to first pass metabolism, which means you won't be able to pick it up in the urine. The larger portion will be absorbed into the capillary blood, and so probably will be accurate in the 24-hour urine or the dried urine, but I don't think that's actually been adequately studied. So keep that in mind if you're using troches or melts. And this is a study that basically showed that after application of topical progesterone, the saliva and the capillary blood levels were very, very, very different compared to those seen in the serum or whole blood. So this is just a really, important paper to remind you that reliance on serum levels for progesterone, if you're monitoring topical dosing, can lead to really underestimated tissue levels, and so you'll end up giving lots more than you need to. So be really careful about relying on serum levels for topical progesterone, because you're going to overdose people like crazy. And remember, if you overdose with progesterone, it's high up in the steroid hormone pathway, and you don't really know what this person's body's going to do with it. They might turn it into pretty much anything else. Okay, testosterone replacement therapy. Creams or gels. Blood levels, the serum level rapidly increases with application, doesn't really reliably reflect dose changing. Any dose changes, so the serum blood levels are probably not the great way to go. Now in the saliva, the levels are a lot higher than the serum, and they're highly variable. They may give a false indication of overdosing, so be careful about that. And in the urine, there's just not really good, in the 24-hour urine, there's not really good peer-reviewed literature detailing what actually happens after testosterone gel or cream. So you probably don't really want to use a 24-hour urine. Now, in a dried urine, the epitestosterone can be measured if there's gonadal suppression due to exogenous testosterone production. If that's what you think is going on, the good news is the dried urine, you can actually measure the epitestosterone, which will tell you whether or not you've suppressed this person's own production of testosterone by giving them some. Now, vaginal or labial application of testosterone, there's not really any good way to get a blood level that makes any sense. The salivary levels, like any other cream or application that we might have it on your hand, you gotta be careful, because If you're handling the specimen vials to get the saliva, you might actually get it into the testing medium. And then just like any vaginal or labial application, if you're trying to get urine specimens, you've got to be careful that you're not contaminating the urine and getting a falsely elevated level. Now, if you're doing testosterone injections, pellets, either injection or pellet, actually, blood levels are a good idea. Get 1/3 baseline, use them for monitoring. It gives you adequate levels. Now, in saliva, you'll get a big elevation in the saliva after an IM injection, but there's really wide variability from person to person. So you have to take that with a grain of salt in terms of how accurate your result might be. Same thing happens in 24-hour urine specimens. You're going to get an elevation after an IM injection, but there's a great deal of variability, so who knows how accurate it is. There is essentially no peer-reviewed literature for the dried spot urine. If you're using a testosterone patch, you can get adequate levels, and there's good studies to show that a blood level will be okay. A salivary level, there's only some correlation to the bioavailable testosterone. Modest correlation, maybe it's going to be a helpful level, maybe not. If you're using a testosterone patch, the urinary levels, both in a 24-hour urine and the dried urine, urinary levels are going to reflect the increasing doses. So you're probably getting a reasonably good level with using that. Now, DHEA. If you're using DHEA treatment, oral DHEA, you're going to get a rapid increase in the blood levels right after the oral supplementation. As you get with the saliva, you get that also in saliva and also in urine. So you're picking up on the fact that you took the DHEA. You'll notice that we're really vague in this chart because the problem here is there is some variability both in the blood results, the saliva results, and the urine results. So you have to take that with a grain of salt. I personally don't like really using a lot of oral DHEA anyway because, like all steroid hormones, your body's going to take it to the liver, and the liver has the opportunity to change it into something else before it even gets into the bloodstream to do its job. So other applications may be more helpful. A transdermal DHEA, topical DHEA, you're going to really end up having to just see how the patient feels in terms of symptoms, because if you use topical DHEA, the blood levels, you're going to get a big rise right after the initial application. So what does that really mean? Because it drops right away. In the saliva, after transdermal application of DHEA, the levels will increase, but not in a linear fashion. So that doesn't really make any sense. And there is really no peer-reviewed research detailing what happens in DHEA levels in the urine after transdermal application. So if you're using transdermal DHEA, you're kind of on your own. Just see how the patient feels. The bigger issue then becomes you might want to keep an eye on what the downstream breakdown products are doing, because you can't, if you're not really able to get a good DHEA level, you might want to at least look at testosterone and estradiol, and that'll give you some feel for if you've overdosed or underdosed the DHEA. Now, with a vaginal or labial application, the levels in the blood don't go up at all, so you can't really use that as a way of monitoring it. There's no research detailing levels after vaginal application, looking at salivary levels or urinary levels. So again, this is going to be just a matter of following the person and how she feels after using it. You're not really going to need to worry about getting any kind of measurement afterwards at all. It's simply clinical. So I hope it makes sense that basically there isn't anything perfect. The test you choose is going to depend on what you're giving the person, the form you're giving it in, and then what you're trying to find out. And we'll talk more about this at the module in terms of treatment. But basically, it comes back to what I said at the very beginning. Find a treatment form that you like, that you feel comfortable with, and then understand whether or not to get testing, depending on the form of replacement you're using, and then making sure that you are actually getting information that is helpful and not misleading. And we will be answering questions about this at the module, and I hope that you guys have found this helpful. And again, I hope you're listening to this before you get to Denver, but if not, make sure you listen to it on the first night so that you can keep up with us. All right, thanks for your attention.